Hello, everyone, and welcome to a very special edition of Tuesday Talks. I'm Seema Kumar, and I'm the CEO of Cure, and it's a pleasure to actually kick off this very important topic today that's focusing on maternal health and maternal mortality rates. Well, believe it or not, there is a significant public health problem that we are facing here in the US today, and that is maternal mortality. Just even in the past 2 years, maternal mortality rates in the US have increased manyfold. And not only that, there's 3 times as much increase in women of color, especially Black women, right here in the United States, the most richest and powerful nation on earth. What is happening? What are we doing about it? What are the reasons? And that's what we're going to focus on today. And joining me today is the CEO of Oula, and that's Adrianne Nickerson. Welcome.
Thank you. It's a pleasure to be here.
Yes, well, first of all, before we get into Oula and what it's doing, talk to me about how significant this problem is, and has it really become more and more acute in the past 2 years, especially after the pandemic?
I think for sure over the past 2 years it's gotten a lot worse, but I think it's easy to sort of discount that and say that was something about COVID. But when you look even over the past 2 decades, for example, the maternal mortality rate has doubled. Right, so a woman today is twice as likely to die in childbirth as her mother was. And so this is, while COVID may have been like an acute exacerbator, I think it highlights a really broken maternal health system that has been true for decades.
Why is it broken? I mean, you would think, when we think of maternal, women dying of childbirth, you think of, our grandmother's generation or even, before that. So this is happening right here, right now. And why is that? Why is the care model so broken?
I think in a lot of ways we built the wrong care model in the United States. When you look at how most westernized countries that have much better rates than we do across maternal mortality and preterm birth rates and NICU stays, what is true about all of them is that they really have midwifery care and team-based care as the sort of foundation of how they built their healthcare system. In the US, it's the opposite, right? 85% of women are gonna be delivered by an OBGYN. And I think having just a really different and distinctly sort of separate care system is really what drives that. And so when I think a lot about like the opportunities to create a different system, I think we get to look a lot of times outside the US to find really the models of care that are working well.
Wow, that's really interesting, because you would think that the healthcare system in the United States should be, is supposed to be, is one of the best. So tell me where Oula comes in, and what does Oula do, and what was the insight, and what was the passion that made you actually found the company?
So at Oula, we combine sort of the best of midwifery and obstetrics to create that team-based model of care to deliver really evidence-based and personalized maternity care. So very much paying homage to sort of the care models that are in the Netherlands, that are in France, that are in all of these countries that have much better outcomes, but also sort of adding to it. When you look at how maternity care is delivered in the US, it looks strikingly similar to the way it was delivered 100 years ago. And almost everything about life has changed. And it wasn't particularly evidence-based then, and for sure it isn't now. And so it felt like there was a huge opportunity to add technology into the experience, to extend care in between visits, and definitely into the postpartum phase. I think what's really surprising for folks often is when you hear something like maternal mortality, you think it happens in the hospital, but nearly 50% of those deaths happen after someone goes home. And so technology is really important in sort of stitching together and reaching and connecting to women in all of those moments when they're not necessarily in a provider's office. So really focused on building that, which means we have clinics in New York, we have a clinic in Brooklyn Heights, we have a clinic in Soho. We have that technology platform that sits on top of it that really reaches patients in between visits. And then we bring sort of connection, care, and community into how we deliver the care. And the impetus, oh, sorry.
No, go ahead. Impetus for it, yes.
Impetus to do it. I got married and was planning on having a family myself and started talking to women. And what I thought people were going to, describe an experience that was joyful and hopeful and all the things that you would kind of imagine would go along with sort of bringing new life into this world. And women described an experience that, like, at best was isolating and impersonal, and at worst actually was really dangerous. I was like, I don't want to go through this experience.
Wow.
And I've spent my whole career working in healthcare.
Yeah.
I've done innovation in oncology. I have a co-founder for this business who's done a ton in primary care, and we're like, how come we've done so many of these things for all of these other patient populations, but why haven't we done it for women? Why haven't we done it in women's health? And so that was really the reason to build it selfishly for myself, but also something that I think could benefit a lot of other women.
Yeah, so how does it work? I mean, like, describe the journey that a typical woman who has just found out that she's pregnant is going to go through, with a technology or a platform like Oula, or does it actually begin even before she gets pregnant?
Most women I say, pee on a stick and call us. So, right, they find out they're pregnant, and then they go through a buying process, right? They're like, where should I go for care? What's so different about maternity care as opposed to maybe cardiology or oncology, where you maybe ask a doctor where to go? Women are asking their friends, and so usually they're hearing about us by other women who delivered with Oula and really love their care. So they hear about us, they go to our website, and they start care virtually. And we did that way because we wanted to be able to be the person that was available first. So often you call, you get pregnant, and the doctor's office tells you, you're not actually important to me yet. Come at 10 weeks when you're clinically valid or relevant. But the woman's like, actually, I have a ton of questions. Like, I hear I'm not supposed to be eating sushi. Like, am I supposed to be changing my meds? Like, all of these things are a really, a stressful moment in time. So you start virtually. We do it as a way to increase access to care. Then women throughout their care with us are going to sort of do mixed modalities. They're going to do virtual care and do visits with our midwifery and OB team when that's appropriate. Sometimes they're obviously going to come in person. I say a lot, you can't give birth to a baby over Zoom, right? So in-person care is really critical to the experience. And then they're also going to have group care, because so often what's important to women and birthing people in this experience isn't just sort of the relationship with their provider. It's actually other women who are experts in their care. And so we do that through group visits at week 32 and at week 37, and then into the postpartum space. And so we bring all of those things together, and it really is personalized to the individual. So what my experience is going to look like is very different than, if you decided to have a kid again and went to Oula, what that experience would look like. And it should be, right? Yeah. It should adjust based on someone's preferences. It should adjust based on their risk. It should adjust based on, honestly, just like what is the best care that we can deliver to them. And the flexibility of having in-person care, technology, and group care really allow us to deliver it.
How do you go about personalizing it, though? Because, there's so many variations from individuals to individuals in terms of even their preferences, their body types, their ethnicity, and age. So many different factors come into play, right? Their social circumstances, their family support, all that. So how do you personalize it? I mean, there's so many things to account for.
So we do it by creating a multidisciplinary care team. So we recognize that some individual is going to need the social worker or the care coordinator. Someone else might need to talk to the midwife more. Someone else might actually need the nurse or the nurse practitioner. And so by creating a really flexible care team that has all of those different sort of components available, we're able to adjust and sort of put the right person in for the job, so to speak, based on what the individual person needs. And I think that's actually what's so distinct from the current system, because this current system is sort of you and an OB. And if the OB can't solve your problem, you're a little bit left on your own. And so by having this team-based approach and really bringing together people who are experts on physical health and emotional health and psychosocial, you're able to sort of adjust the care model and the journey for what's right for the individual in front of you.
Where's the technology part come into play? Because, obviously, when you're adjusting the care model for all of these varying factors, I'm assuming you'll have to rely on technology.
Last time you went to book a doctor's office, were you able to do it online, or did you have to call?
Online.
That's an exception. I feel like so often, particularly for OB care, you can't even book your first appointment online because they want to decide if you're actually the right person for them to take. And so we focus first on building what I'd say table stakes features. Right? How do you build a modern and convenient experience for consumers? They need to be able to book their appointments online and change them. They need to be able to view their lab results and test results. They need to be able to message you at 2 in the morning or 2 in the afternoon about things that have changed in their history. They need to be able to see content and information that's really relevant to the journey that they're on and the decisions that they want to make. So we do a lot of the sort of patient-facing technology that's all about making it an easy, seamless experience. But then we've actually built a lot of technology internal that is what our care team uses and sits on top of our EMR and allows us to deliver that coordinated care.
Yeah.
Because in order to do team-based care, in order to talk to a midwife one day and a nurse the next and a care coordinator on our team, they all need to be working from sort of like the same script.
Yep.
And so our technology helps deliver that standardized care pathway. And it's like a CRM pulling the most relevant information about the patient up to the surface so it's available for any person who's interacting with the patient. And then we have a whole data analytics section which just helps us run a good and healthy business.
That's great. That's excellent. So how long has the business been in existence?
So we raised seed capital for the business in 2020 and opened our first clinic in 2021. I know it took us about 9 months to do it because I got pregnant with my first kid, opened the doors to our clinic.
But then you had personal experience to
yes.
rely on, right? As you were,
I was Oula patient number 1.
Yeah, great. Excellent. That's great. And since then, have you raised more capital?
We've raised $22 million to date. So yeah, we raised a Series A about a year and a half ago.
Excellent. Congratulations.
Thank you.
Yeah, so what's the future for Oula and who are your key competitors?
So we generally compete with sort of the doctor's office down the street, which honestly, the bar is so low sometimes in healthcare, it feels like we're not really competing. But in terms of growth, I think we're focused on continuing to scale a care model that really works. So we measure ourselves in a couple different ways. We built Oula to obviously tackle the challenges that we saw in outcomes, but also in experience, because I don't think you can divorce the two.
Yep.
And so we're really proud to have a net promoter score of 94, right? Women really love their care.
Excellent.
But probably more importantly, we compare ourselves to benchmarks, and our C-section rate is 25% less than New York City's for our sort of comparable population. Our preterm birth and our low birth weight babies, which obviously, can you imagine anything more tragic than a kid ending up in the NICU, are about half benchmark as well. And so we have really good outcomes, so we're focused on how do we scale that. And we scale that through partnerships with health systems. And so we're partnered in New York with Mount Sinai, who's been a really wonderful institution for us to work with, and are continuing to work with other health systems to build this, beyond New York City, because while New York is honestly one of the worst places in the country to give birth, you gave the statistic of around Black women having a 3 times higher likelihood of dying. In New York City, it's 12 times.
Wow.
So it's particularly acute here, and so we have a lot of reason to build and continue.
Yeah, let's pick up on that point. So a couple of things. Let's, we are here in New York City, right, here at Cure. Talk a little bit about, what the situation is and what does the public health numbers for maternal mortality look like, just in general for women, but then, the statistic about Black women, 12 times more likely. Talk a little bit about, first, let's hear the statistics first, and then we'll dive a little bit deeper into why that is.
I mean, in terms of statistics, I think the thing about maternal mortality to realize is it's sort of the canary in the coal mine, right? And so while the rate, as we mentioned, has doubled, for every woman who unfortunately dies through what should be one of the most joyful experiences, there are thousands of more that experience really severe morbidity through the experience, and really severe complications, or even postpartum depression that isn't caught and treated. So even though I think the focus tends to be on maternal mortality, because it's like a statistic that we all see,
there's a morbidity part.
It's really just shows you like one picture or one point of the larger problem in the system today. And so the folks that obviously experience it the worst in the US is unsurprisingly Black women, and that is true in New York. It's true because systemic racism exists, and it persists through the medical industrial complex that unfortunately women access in order to get their care. I think a lot of the reasons why we see it worse, beyond the fact that obviously systemic racism drives it, is in pregnancy it's so important to have a trusted relationship with your provider. And communication is core to having a good experience. You need someone that you feel like you can trust to say, I don't feel well. I feel like maybe my swelling has increased, or I'm experiencing shortness of breath. And if you don't think that the person on the other side is going to listen to you, you're not going to raise that.
Yeah.
And so when you look particularly for Black identifying women, like that's an experience that they have over and over and over again, as really feeling not heard and not listened to in the system.
Yeah.
And so that just percolates in poor outcomes that we see.
Yeah. You know, there's a whole gender part of the equation too, right? Like zooming out again, women typically have felt like even when they have what they think is a heart attack, right? They show up at the doctor's office or they show up in the ER and it's nothing more than indigestion. So a lot of times women's expressions of, you know, what they're feeling in their bodies go ignored. Is this because the healthcare system is so male dominated, or we haven't focused enough on women's care?
Can it be both?
Yeah.
I saw a statistic recently that said, I think it's 46% of women have experience with their provider feeling either dismissed or blamed or ignored. I mean, that's almost half of women. Like, that's stunning.
Yeah.
I think, you know, there are a couple of different things that drive it. I would argue fee-for-service reimbursement drives it, particularly in New York City and across the country. It's like a factory going to the doctor. Maybe you get 5 minutes with them. And how do you build a real relationship? And how do you get great clinical care? And so I think that is for sure a piece of it. And then the things that we've also known, which is women have been left out of, you know, clinical research and studies. And so if, you know, women present with really different symptoms for heart attacks than men do, and we never really studied it, then are we surprised to see the outcomes? And so I think there are a lot of things in the system that drive the poor experience. I don't know, it's hard to pinpoint just one.
Yeah. So, you know, the mortality, and then we'll come back to, you know, other outcomes and Oula and what's Oula thinking about for the future. So what are the real, what do women ultimately die of? Is it post-birth complications? What is it? Because it's one of the most preventable things, right? Maternal mortality is a preventable condition. So what goes wrong, and why does it lead to that kind of an extraordinarily bad outcome?
Yeah, I mean, parts of it are we over-intervene in this country, right? So our C-section rate is generally over about 30%. The WHO says it should be 10%. So the first C-section, usually not a problem, maybe not even the second, but someone who has a third or a fourth, you're continuing to open the same wound, which increases the likelihood of a really severe event. So part of it's just like the way we practice medicine in this country drives increased risk, which drives increased poor outcomes. Another part of it, a lot of the reasons why we see an increase in maternal mortality happens in that period I mentioned after someone leaves from the hospital. So about 50% of the deaths happen there, and a lot of them are actually cardiac related. So going back to your heart attack, pregnancy puts an enormous amount of stress on the body. You like double your blood volume, so it's a lot of stress on the heart. And when the routine visit after you leave the hospital is 6 weeks later, how are you going to catch it? You're not even talking to the woman. Like the pediatrician has to see the baby the next day after you leave the hospital, and yet we don't check on women for 6 weeks, and we wonder how we are going to miss the cardiac complication.
Wow. That is something I did not know, that it's a cardiac complication, 50% of the deaths.
Well, 50% happen postpartum, and most of them are cardiac related. There are also a fair amount in that space that are, unfortunately, you see suicide, you see sort of postpartum depression driving poor outcomes. Poor outcomes,
So how are you at Oula going to measure success? And what are you going to be measuring outcomes like that? And how many women do you have now in your network?
So we've delivered, I think, just about our 900th baby. So in 2 years. A lot of Oula babies out in the world. I mean, we measure success mainly in how our patients do. How our patients do from how they talk to us about their care, so both qualitative and quantitative. I mentioned we track down promoter score because we think it's a great way to really understand not only did you like care, but would you tell a friend about it? Would you tell a family member? Like that's a higher bar, and so to have a 94, because it's like unheard of in healthcare. So that's really important to us because I think as much as avoiding a really severe outcome is important, it also matters that you just feel seen and heard in your care. And for most women who are going to have a normal, safe pregnancy, like that still matters and that should count. So we're focused on that. And then, we're focused on outcomes, right? We track our, we don't track maternal mortality. We've had no maternal deaths. I mean, there are only 1,200 that happen in this country, right?
Yeah.
It's a very small N. That's why I go back to like, it is the indicator of all of the other problems. It's
Yeah.
not the maternal death in and of itself.
Yeah.
And so that's why we're looking at C-section rates, knowing that over-intervention is what drives a lot of downstream
Yeah.
poor experience and cost.
Yeah.
It's why we're looking at preterm birth, because when you think of what are the best ways that I can impact preterm birth, there are parts of it that are obviously going to be genetic, and we're not going to change that, but there are parts of that are about really the stress that women go through during pregnancy and how that impacts the likelihood of their baby delivering early. And if you can change the way that you support that woman during their prenatal care, you can actually change that outcome. So that's doing things like understanding, do they have transport to their visits? What's going on at home? How are they doing emotionally? All of those other pieces are so key in driving that outcome. And so we focus on preterm birth because it really is this indicator of like how well we were doing in our whole prenatal care.
Yeah. That's great. So tell me about you. What is your background, and why did you decide to go this route, based on your personal experience?
Well, I got a master's in public health right after school, and I focused on women's health, and particularly sexual and reproductive health. It's an area I've loved, and I sometimes I reflect back, like, why is it something I care so much about? And I think it's because I grew up with 3 brothers, and so I'm uniquely sort of attuned to the experiences
Of being
that are different for women, because I kind of watch how they operate in the world.
A woman amongst men, yes.
And I think the choice to have a kid is also such a huge inflection point for that same reason. It impacts like your self-identity so much as a woman, your relationships, your economic opportunity, like how does it impact your work, educational attainment. There are just so many things that are caught up in this choice. And I think we can actually create a better and more equal society for women if we do a better job in this transition point. But for the most part, we don't, right? We sort of check their fetal heart rate and we check their blood pressure and we send them on their way and don't recognize that they've gone through this like huge life transition and create no sort of support in our healthcare system for them.
Yeah, so, now it's congratulations for all the work that you are doing in Oula, but what do we do about the whole problem writ large? What changes should happen in the healthcare system?
I mean, we're huge advocates of midwives, of course, right? They're the key and cornerstone of our care model. But a lot needs to be done for workforce development. I think the fact that we don't have a residency equivalent program for folks out of midwifery school means that they don't have the same sort of training and the same grants that sustain folks going into the profession. And so we really need to invest in that, particularly going back to our comments on the fact that maternal mortality has a disparate impact on Black women. We need to focus once again back on the workforce and say, how do we ensure that there's a pipeline of BIPOC providers? When only about 6% of midwives are Black, that's a problem. We know racially concordant care delivers better outcomes, and so I think there's a ton to be doing on just diversifying and investing in the workforce. We need to continue to invest in technologies that extends care between visits and well into postpartum. I think we're doing more and more in remote monitoring, which is amazing, right? We're seeing differences in folks' blood pressure and using that to identify preeclampsia early and changing the way that we treat patients. And so continuing to get more data from individuals pre and post that we can use to deliver better care will continue to be good. And honestly, we just need to invest more in women and women's care. When you look at 45% of women in this country get their care through the Medicaid system, and we continually underfund a system that disproportionately serves women and children. And I think until we actually, as a society, say women matter and put money into that system, it's going to be hard to also change that.
You want to say that again? Yeah. Thank you, David.
I don't remember what I said, though.
That's okay. No worries.
What was the last question?
So I was going to ask how we're going to change the system as a whole. Yes, you're doing great work at Oula, but what about the society at large? How are we going to make sure that we are looking at system-wide changes? What would you recommend?
I mean, the first thing I would focus on is really workforce development. we have midwifery care as the cornerstone of how we deliver our care, right? We're really flipping the pyramid. If 85% of births in this country are by OBs and maybe 10% are midwives, we need to flip that. And so continuing to invest in that workforce, which doesn't have a residency equivalent that an OBGYN has. So they don't get sort of funding for additional training. We also have a particularly white workforce, right? 6% of midwives identify as BIPOC. When we know that racially concordant care delivers better outcomes, if we have a maternal mortality crisis that's particularly acute for Black women, we need to change the makeup of the workforce to really impact that. We need to continue to invest in technology. We've seen huge advancements in sort of remote monitoring for indicators like blood pressure, which we know drive preeclampsia and have huge overall cost and impact to human lives. And then I'd say the third thing is really, honestly, investing more in the Medicaid system. 45% of births in this country are covered through Medicaid, and we underfund the system. And until we as a society decide that we value women and children more and put money behind that system, I think we're going to continue to see a really fragmented, broken system because providers just don't have the time that they need to spend with patients to really deliver the better care.
Yeah, so we really need to, drive home the fact that women and women's health are important healthcare priorities that we as a society must invest in, right? Yeah.
Yes, that we should value them as much as we value seniors, right? Because we fund the Medicare system in a very different way than we fund the Medicaid system.
Medicaid system, yes. That's really great insight. And what is your hope for Oula 5 years from now?
I want to be in every major metropolitan city to be serving, having probably at that point 30 clinics to have at that which will have 15 times our impact. And more importantly, I think we're showing how to make a sustainable business. And I think that is also what changes the system. When you can show that by delivering better experience and better outcomes, that you can build a sustainable clinic, it's a thing that makes health systems think about sort of the care differently and do the things and partner and find ways to sort of expand access to midwifery care. It's a thing that changes payers' minds because they love to see fewer C-sections and fewer preterm births, and so they're really aligned. And I think by being able to continue to expand and make Oula successful, we can actually create shifts in the paradigm of how this care gets paid for. That means all boats rise, right? So it's more than just Oula delivering this impact.
That's great. That's really wonderful. And thank you for the great work that you do. And thank you for the work that you do in supporting women and women's health, but also being such a big advocate of women. Thank you so much for joining us on Tuesday Talk.
Thank you. It's been so fun. I appreciate the time.